due to muscle paralysis or paralytic or muscle restriction or restrictive strabismus. Incomitant strabismus or paralytic strabismus. Definition of paralytic strabismus is it's an abnormal deviation of one eye, and this is the definition of strabismus, with unequal angle of deviation in different directions of gaze and abnormal ocular motility. And this is the definition of incomitant. Due to extraocular muscle paralysis or paresis, and this is the definition of paralytic. So if you measure the angle of deviation in the primary position, for example, it's 30 prism diopters. On gaze towards the affected muscle, the paralyzed muscle, the angle increases to become, for example, 70 prism diopters. And on gaze to the other side, where there's no limitation, the angle can go down to 0. So the angle of deviation is unequal in the different directions of gaze. And there is abnormal motility because there is paralysis of a muscle. Causes of paralytic strabismus. Lesions of the motor nerve nucleus or the nerve trunk or the muscle. Lesions of the motor nerve nucleus, the nucleus lies in the brainstem. The nucleus of the third and fourth cranial nerves lies in the midbrain, and the nucleus of the sixth cranial nerve lies in the pons. Lesions of the nucleus could be a congenital absence of the nerve nucleus, or inflammatory, as encephalitis or disseminated sclerosis, or degenerative or vascular. Lesions of the nerve trunk could be traumatic, severe head trauma that cause injury to the nerve trunk, or trauma by compression. Compression, for example, by an aneurysm or a tumor compressing the nerve trunk and causing its injury. Or it could be diabetic, which affects the microvasculature of the nerve, causing ischemia of the nerve and its paralysis. Muscle lesions, for example, congenital absence of an extraocular muscle, and this is extremely rare, or traumatic trauma, for example, to the globe or to the orbit, the muscle can be cut. Or myopathy, which is a disease that affects muscles and can affect muscles all over the body. And the nerves to be affected by paralysis are the third nerve, the fourth nerve, and the sixth nerve. As we mentioned earlier, the third nerve supplies the superior rectus, inferior rectus, medial rectus, inferior oblique, and also supplies the levator palpebrae superioris, which opens the eyelid or elevates the eyelid, and it also supplies two intraocular muscles, which are the ciliary muscle responsible for accommodation and the sphincter pupillary muscle responsible for meiosis or constriction of the pupil. The fourth cranial nerve or the trochlear nerve that supplies the superior oblique, and the sixth nerve or the obtusant nerve that supplies the lateral rectus. So any of these nerves could be affected and could be a cause of paralytic strabismus. So causes of paralytic strabismus is third, fourth, or sixth cranial nerve palsy. Presentation: the patient presents with diplopia and a manifest ocular deviation. By examination, there is a manifest incomitant ocular deviation. The eye deviates to the opposite side of the paralyzed muscle. For example, this child has a right sixth nerve palsy, causing a right lateral rectus paralysis. So the lateral rectus is paralyzed, the medial rectus is normal and acts against the paralyzed muscle, so pulls the eye in its direction, causing right esotropia. There is incomitant strabismus. As seen in the middle picture, there is right incomitant esotropia due to right lateral rectus paralysis, and there is marked limitation of the lateral rectus, as seen in the picture on the left-hand side, the first picture. The boy is trying to look to the right. The left eye is normal and moves inwards by the medial rectus, but the right eye has paralyzed lateral rectus muscle, so cannot be abducted or moved out. And on gaze to the left side, both eyes move normally. So the angle of strabismus is moderate in the primary position, it's very large on gaze to the right, and there is almost no strabismus on gaze to the left. So this is incomitant strabismus, which means unequal angle of deviation in different directions of gaze. The angle of deviation is maximum in the direction of the paralyzed muscle. There is limited ocular motility. Here there is right limited abduction due to right lateral rectus paralysis. And the third manifestation is diplopia. It's binocular because the brain cannot fuse the images perceived by both eyes, because the image falls on the fovea in one eye and does not fall on the fovea of the other eye. And if we close any eye, if we cover any eye, the diplopia disappears, because there will be only one image perceived by the brain, by the uncovered eye. So diplopia is always binocular. Any diplopia related to strabismus is always binocular. And this diplopia is maximum in the direction of action of the paralyzed muscle, which means that the two images become farthest apart when the patient looks in the direction of action of paralyzed muscle. Compensatory mechanisms to overcome binocular diplopia could be by closing one eye to see only one image by the other eye, or by acquiring an abnormal or a compensatory head posture. The girl on the left-hand side, she's acquiring a right face turn to move her eyes into left gaze to avoid the position of a right lateral rectus paralysis. So she moves her eyes in the direction of the paralyzed muscle. She moves her face in the direction of action of the paralyzed muscles to move the eyes in the opposite direction to keep them away from the position of muscle paralysis and avoid diplopia. And this baby has superior oblique paralysis of the right eye. So to overcome diplopia, he performs a face turn and a head tilt to the opposite side and a chin depression to overcome diplopia, to put the eyes in the position where there is no action of the paralyzed muscle, where the muscle does not act. So there is an abnormal head posture. This is one of the manifestations of paralytic strabismus, an abnormal head posture where the head is turned towards the direction of action of paralyzed muscle to move the eyes in the opposite direction to avoid diplopia. So this girl has right lateral rectus paralysis, so she's acquiring a right face turn to move the eyes into left gaze away from the position of action of the paralyzed lateral rectus muscle. So to summarize, signs of any form of paralytic strabismus, we talk about 4 points: a manifest incomitant strabismus, limitation of ocular movements, binocular diplopia that's overcome by an abnormal head posture. The first cause of paralytic strabismus is paralysis of the abducent or the sixth cranial nerve, or a lateral rectus palsy. The clinical picture of sixth nerve palsy, as we mentioned, we talk about 4 items on talking about any nerve palsy: diplopia and the compensatory head posture to overcome that, and the type of strabismus and the type of limitation of motility. Diplopia, as we mentioned earlier, any type of strabismus will produce binocular diplopia. Diplopia is always binocular in any form of strabismus. So diplopia is binocular, and as the sixth nerve supplies the lateral rectus, which produces only abduction, just one horizontal action, so the diplopia is horizontal. The 2 images are seen next to each other, not above each other. So the diplopia is binocular and horizontal. and the diplopia increases in the direction of action of paralyzed lateral rectus muscle. This means the two images become very far apart when the patient looks in the direction of action of the paralyzed muscle. And there is a face turn in the direction of action of the paralyzed lateral rectus. So a right lateral rectus paralysis produces a right face turn to move the eyes into left gaze and avoid diplopia. There is incomitant esotropia because the medial rectus pulls the eye in its direction against a paralyzed lateral rectus muscle. And there is limitation of abduction because the lateral rectus is an abductor. This man has left lateral rectus paralysis. He's acquiring a left face turn, which is a face turn in the direction of action of the paralyzed left lateral rectus to move the eyes into right gaze. So the picture in the middle shows a left face turn. The first picture, there's normal motility on gaze to the right, but the picture on the right hand side, there's limited abduction of the left eye due to left lateral rectus palsy. This lady has a right lateral rectus palsy, so she's acquiring a right face turn, and there's limited abduction of the right eye, but normal motility to the left. And again, this boy, he has right lateral rectus palsy with a manifest incomitant esotropia, where the angle is maximum in the right gaze, i.e. in the direction of action of the paralyzed lateral rectus, but the angle is least or almost zero prism diopters in the opposite direction. This girl has a right sixth nerve paralysis causing a right paralytic esotropia and marked limitation of abduction of the right eye. So to summarize, the clinical picture of a sixth nerve palsy, there is diplopia, which is binocular and horizontal. Diplopia increases in direction of action of the paralyzed lateral rectus muscle. And there is a compensatory face turn in the direction of action of the paralyzed lateral rectus to overcome the diplopia. And there is incomitant esotropia and limitation of abduction. The etiology of a sixth nerve palsy could be microvascular, where the small blood vessels affecting the nerve are affected. The small blood vessels supplying the nerve are affected. The microvascular causes could be due to diabetes or hypertension, or could be due to a space-occupying lesion like brain tumor or an intracranial aneurysm compressing the nerve trunk, or could be due to high intracranial pressure, which is idiopathic intracranial hypertension. And this is a false localizing sign because cases of high intracranial pressure with no space occupying lesion, just high intracranial pressure, the brainstem is pulled down. And this causes stretch and compression of the sixth nerve as it crosses the petrous part, the sharp edge of the petrous part of temporal bone, causing its affection. But actually there is no lesion, no tumor, no aneurysm compressing the sixth nerve. It's a false localizing sign because it does not truly localize a tumor. It's just due to general increase of intracranial pressure and compression of the nerve against the sharp edge of petrous part of temporal bone, causing its paralysis. Another cause of sixth nerve paralysis is trauma, severe head trauma, for example, otitis media, which usually occurs in small children after a cold, or could be viral affection of the nerve. The second nerve to talk about is the oculomotor or third cranial nerve palsy. The oculomotor nerve supplies as we mentioned earlier, all extraocular muscles except the superior oblique and the lateral rectus. Another extraocular muscle that does not move the eye but elevates the eyelid, which is the levator palpebrae superioris. the sphincter pupillae and the ciliary muscle, which are two intraocular muscles. To paint a picture of third nerve palsy, ptosis, because the nerve supplies the levator palpebrae superioris. So the patient will not complain of diplopia and therefore will not acquire an abnormal or a compensatory head posture. The patient will get incomitant exotropia as the eye is pulled out by the intact lateral rectus muscle against a paralyzed medial rectus muscle. And there is limitation of ocular movements in all directions except outwards because the lateral rectus is intact. Although the superior oblique is intact, the superior oblique depresses the adducted eye. And here the medial rectus is paralyzed, so cannot adduct the eye for the superior oblique to act. And the superior oblique cannot depress the abducted eye, which is abducted here by the lateral rectus. So we cannot depress, the patient cannot depress the eye because it's abducted, and the superior oblique cannot depress the abducted eye. So how can you determine if there is also superior oblique palsy or not? If we ask the patient to look down and in, there will be intorsion movement of the globe by the superior oblique. So if there is intorsion, there is normal superior oblique. If there is no intorsion, the superior oblique is probably affected as well. So there is incomitant exotropia, limitation of ocular movements in all directions of gaze except outwards due to intact lateral rectus. There is a dilated fixed pupil as the third nerve supplies the sphincter pupillae, and there is loss of accommodation as the third nerve supplies the ciliary muscle. So the patient, if we raise the upper lid and ask the patient to read, the patient will complain of difficult reading, blurred near print. However, the patient does not complain of loss of accommodation because he has ptosis. This is a picture of left third nerve palsy. There is left ptosis, and if you raise the left upper lid, we can see that the eye is exotropic and there is limitation of movement in all directions except abduction. Here, the limitation of depression is mild, not marked, because the affection of the branch to the depressors of the eye is mild in this case. Etiology of third nerve palsy. The most common cause is an intracranial aneurysm of the posterior communicating artery, and in this case the pupil is dilated because the pupillary fibers lie at the outer part of the third cranial nerve. So if an aneurysm compresses the nerve, the pupillary fibers will be affected early and the pupil will be dilated. Other causes of third cranial nerve palsy are a space-occupying lesion like a brain tumor, trauma to the nerve, or microvascular diseases like diabetes or hypertension. And these supply the microvasculature of the nerve. So the pupil in this case is spared because the fibers supplying the pupil are on the outer part of the nerve, and diabetes and hypertension affect more the inner part of the nerve. So if the pupil is dilated, this points to a space-occupying lesion like an aneurysm or a tumor. If the pupil is spared, normal pupil, the cause is probably diabetes or hypertension. So investigations of a case of third nerve palsy to diagnose the cause, neurological examination, laboratory investigations, especially blood sugar to exclude diabetes, imaging, and urgent MRI, magnetic resonance imaging, and angiography is indicated in cases of pupillary affection to detect a tumor or to detect an aneurysm by the angiography. The last cranial nerve is the trochlear or the fourth cranial nerve paralysis. The fourth nerve supplies the superior oblique muscle. Clinical picture of trochlear nerve palsy. As there is paralysis of the superior oblique muscle, which depresses the adducted eye, the patient cannot depress the adducted eye, so complains of difficult reading, because this is the position of reading. We look down and in to read, and the patient cannot look down and in, so he complains of difficult reading. There is diplopia, which is binocular, and it's vertical, horizontal, and torsional, because the superior oblique has vertical action, depression, and horizontal action of abduction, and a torsional action of intorsion. So the image will be high, the two images will be above each other and laterally displaced and tilted. So there is binocular diplopia, which is vertical, horizontal, torsional, and it's more on down gaze, which is the field of action of the superior oblique muscle. To overcome diplopia, the patient acquires an abnormal head posture, which has the three components of an abnormal head posture: a tilt, a turn, and a depression. There is head tilt and face turn towards the opposite shoulder, and there is chin depression. Why? The superior oblique is an intortor. So the patient performs a tilt to the opposite shoulder in order to extort the eye. When there is tilt to the opposite shoulder, the eye will move in the opposite direction, so it will be extorted. And the superior oblique is a depressor in adduction. So the patient is trying to avoid the adducted position by performing a face turn to the opposite side in order to abduct the eye and avoid the field of action of the superior oblique muscle. And the superior oblique is a depressor, so the patient acquires a chin depression to move the eye up and avoid the depressive effect of the superior oblique to elevate the eye. So there is a head tilt, a face turn towards the opposite shoulder, and chin depression. The next manifestation of superior oblique paralysis is a hypertropia, because the superior oblique is a depressor, so its paralysis will cause hypertropia as the eye will be pulled up by the intact superior rectus and inferior oblique. There is limited depression in adduction, which is the field of action of the superior oblique muscle. So there's difficult reading, diplopia, compensatory head posture of the three components, hypertropia, and limited depression in adduction. This is preoperative and postoperative. So patients presenting with an abnormal head posture, the cause could be, and usually, an extraocular muscle cause. And treatment is by surgery on the extraocular muscles and not by neck surgery. This lady has an abnormal head posture of a right face turn, a right head tilt, and mild chin depression due to left superior oblique paralysis. And on straightening her head, we see the left hypertropia, as the superior oblique is a depressor and it's paralyzed, so the eye is pulled up by the intact elevators of the eye. The cause of fourth nerve paralysis could be congenital, and this is a common cause of fourth nerve paralysis. Usually it's congenital trochlear nerve palsy, or could be acquired due to diabetes or hypertension or a severe head trauma. Treatment is treatment of the cause. We have to find out the cause first. Is it diabetes or hypertension? We have to treat these. Or if it's congenital, there's no treatment of the cause. We just go for surgical treatment. However, for any case of paralytic strabismus, we have to wait for 6 months before surgery for the possibility of spontaneous improvement. While we are waiting for spontaneous improvement, To avoid a persistent compensatory head posture, the patient could either patch one eye, or better, prisms can be used to relieve diplopia while waiting for the spontaneous improvement of the paralysis. So this is treatment of paralytic strabismus by prisms. This girl is acquiring a right face turn due to right lateral rectus paralysis, and when she was prescribed prisms, she straightened her head. The last type of strabismus is the restrictive strabismus. Incomitant restrictive strabismus. Due to muscle lesions, for example, in thyroid eye disease, where there is inflammation followed by fibrosis of the extraocular muscle, and this fibrosis causes tightness of the muscles. The most commonly affected muscle is the inferior rectus. There is tight or fibrosed inferior rectus. So the superior rectus, although it's normal, it cannot elevate the eye because the eye is pulled down by the tight inferior rectus muscle. So it's a restrictive and not a paralytic form of strabismus. Or could be due to an orbital floor fracture, where there is entrapment of the inferior rectus in this fracture. And in this case, the superior rectus, although intact, it cannot elevate the eye. Thank you.